We will get started. Thank you, everyone, so much for coming today. My name is Jennifer Noel, and I'm the Program Manager for the Education and Outreach Core at the University of Vermont Center on Rural Addiction. We call ourselves UVM CORA. I'm also here with Center Director, Dr. Stacy Sigmund, and Education and Outreach Research Assistant, Eleanor Broy, who will help to facilitate this webinar today. And as you are entering, your cameras are off and you are automatically muted. So today's webinar is entitled The Fourth Wave of the U.S. Overdose Crisis, Disseminating Incentive-Based Interventions for Stimulant Use Disorder into Rural Community Centers or Settings. And this is presented by Dr. Tyler Erath. The Community Rounds Workshop Series is a live webinar series held by UVM CORA, and our goal is to provide opportunities for health professionals and community partners to learn and ask questions. We discuss topics related to science-based best practices for substance use disorders. So before we get started with the webinar, we have just a couple of reminders to go over. We do encourage you to ask questions, so feel free to enter those into the Q&A box, which you'll see at the bottom of your screen most likely, as indicated by that red arrow. And we will review your questions during the Q&A session at the end. This session is being recorded and will be delivered along with the slides to your mailbox next week. We also want to let you know that just after our speaker has finished his presentation and just before we have our Q&A, we're going to share with you a very brief poll to help us with our evaluation, and we would love for you to complete this 1-minute poll. You're going to see it pop up right in the middle of your screen. If you're comfortable now, we'd love to have you use the chat box to introduce yourself to the group. You can share your name, your organization, what community you're coming from. We love to see all the people that are here and where folks are from. And we also would be grateful for any comments that you'd like to share about the webinar itself. When you are commenting, be sure to select everyone so that other participants can see your comments. We're pleased to offer live captioning for today's event, and to access the captions, please see the chat box. We'll be providing a link to that. Continuing education credits are available both for those who attend this session live and those who watch the recording of the session within 1 month of the live event. And during the webinar, we're going to share the link to the chat in the chat for instructions on how to claim your credits. You're going to get these same instructions by email when you receive the recording and the slides. And if you have any questions, you can always contact us at cora@uvm.edu. We do ask that you claim the credits within 30 days of the live webinar. So there are no disclosures for this community round session, and all potential conflicts of interest have been resolved. So I'm going to stop sharing my screen and let Dr. Erath share his. And while he's doing that, I'd like to welcome Dr. Rick Rawson, who will be introducing our speaker today. Dr. Rawson is a research professor at the the Vermont Center for Behavior and Health at UVM. He's also a senior advisor for UVM CORA and a professor emeritus at the UCLA Department of Psychiatry. Dr. Rawson, I'll hand it over to you.
Thank you very much. I'm very happy today to be asked to introduce Tyler. Tyler Erath is a postdoctoral research fellow at the Vermont Center of Behavioral Health at the Larner College of Medicine, the University of Vermont. He received a PhD in 2021 from the University of Kansas in behavioral psychology. His research is focused on behavioral health in a variety of areas, but primarily in the area of substance use disorder. He's doing work now on tobacco. And with me, I've had the good fortune of working with Tyler for the last 2 years on a whole variety of policy and practice issues in the area that he's going to talk about today, stimulant use disorders, and what we can do about providing services. He's published some articles recently, and we're currently doing a project down at Safe Recovery syringe service program that is, I think, going to produce some very interesting findings. So I'll now turn it over to Tyler, and Tyler, knock it out of the park.
Thanks, Rick. Yeah, the fortune's been mine. Screen looks good. So thank you, Dr. Rawson, for the introduction, and good afternoon, and thank you to everyone for being on today's call and for the opportunity to present at today's community round. So thank you to CORA. Today, I'm going to be discussing the fourth wave of the overdose crisis and the dissemination of incentive-based interventions for stimulant use disorder. In doing so, there are several objectives I hope to review. First, I'd like to spend some time reviewing some epidemiological data on the current role of stimulants in drug-involved overdose deaths in the US. Second objective is to review data about evidence-based treatment for stimulant use disorder and contingency management as a treatment. Then much of the rest of today's talk will be focused on describing current challenges to using CM, current efforts to overcome those obstacles, reviewing some protocol considerations, the potential role of technology, and then some considerations for implementation in rural settings. And finally, I wanted to spend some time discussing the potential role of certificate programs as potential training opportunities for health professionals, including individuals in rural areas and rural settings. So as we're currently in the ongoing overdose epidemic, one of the questions I wanted to start by posing is, why should we be concerned about stimulant use? Well, the current overdose and really the broader public health crisis involving illicit drug use is often referred to today as an opioid or a fentanyl crisis. And clearly there is extensive data on the profound damage from opioid use over the past 20 years, and specifically on fentanyl use over the last handful of years. However, there is also an extensive array of data now suggesting that there's more to the current crisis than opioids and fentanyl. And this, what's being categorized as a fourth wave of the epidemic, it's easy to see the impact of fentanyl as depicted by the red line in this figure. However, the overdose death rate associated with psychomotor stimulants, so this includes cocaine and methamphetamine, has also dramatically increased in recent years, with stimulants currently playing a major role in the US as well. So data for stimulants is depicted by the blue line in the figure. And what these data show is that between 2015 and 2020, overdose deaths involving stimulants increased by over 180%. In 2021, there were over 106,000 drug-involved overdose deaths in the US, which was a record high, and then an astonishing twofold increase from about 52,000 deaths in 2015. And over this time, stimulants have also been contributing to record numbers of overdose deaths. So as seen here in figure number 6, overdose deaths involving stimulants, either alone or in combination with synthetic opioids, have risen from approximately 12,000 deaths in 2015 to now over 53,000 deaths in 2021, or they were found in about 50% of deaths in 2021. Prior to 2007, cocaine was the most common drug involved in overdose deaths. And then from about 2007 to 2013, this shifted to prescription opioids, followed by heroin in 2014, fentanyl analogs in 2016, and now really it's mainly polysubstance use involving both fentanyl and stimulants. Relatedly, Friedman and Shover published a paper last year examining polysubstance use and overdose deaths from 2010 through 2021, and looking at this by year, state, and then some other demographics. Using data from the CDC Wonders database, the researchers reported the annual percentage of overdose deaths that involved 4 different groups. So those that either involved fentanyl, stimulants, a combination of fentanyl and stimulants, and then neither fentanyl nor stimulants. And so this was over a little bit over a decade from 2010 through 2021. Additionally, they also measured the most common co-involved substance at both the state level and then across the study period. And so all deaths with an underlying cause of overdose were selected. What they found was that the percentage of overdose deaths involving both fentanyl and stimulants, this rose an astounding 60-fold. So all the way from just 0.6% in 2010 to over 32% in 2021. And so these data are depicted by the purple bars in the figure. The percentage of overdose deaths involving fentanyl without stimulants rose from about 7% to a peak of about 36% in 2020. And then this declined just a little bit to about 34% in 2021. And so those data are depicted in the blue bars. Then the proportion of deaths with stimulants and no fentanyl, which is depicted by the red bars, this one remained somewhat relatively stable over time, with about 15% in 2010 and increasing to 18% in 2021. However, even though this percentage remains somewhat stable, what this means with the growth of the overdose epidemic is that in terms of 2021 overdose deaths, stimulants without opioids were detected in the deaths of about 19,000 individuals. The analysis by Friedman and Shover also suggested some interesting regional differences in overdose death data by differing in the type of stimulant that was most commonly used. So the data depicted on the screen here are for the most common co-involved drug and overdose deaths by state and then by region. And the color coding for each substance is listed at the top of the figure. In 2010, fentanyl was most co-involved with prescription opioids, followed by alcohol and then benzodiazepines. And we see the earliest shift in the pattern of use occurring in the Northeast. So as you can see here, in about 2019, cocaine was the most co-involved substance with fentanyl, which was observed in 7 of 9 states. And then by 2021, we see that stimulants were the most co-involved substance in all Northeast states, so 7 for whom it was cocaine, and 2 for whom it was methamphetamine, so in Maine and New Hampshire. Then over in the West, in 2010, the most co-involved substances were prescription opioids, benzodiazepines, and alcohol. And by 2021, we see that methamphetamine was the most common across all 13 states. In the Midwest and South, there were initially some periods of heroin and fentanyl co-involvement. However, similar pattern here by 2021, methamphetamine and cocaine were predominant in all 18 states and DC, indicating this general shift that we're seeing across the United States. This figure depicts the percentage of fentanyl overdose deaths containing another drug class, separated by the type of drug. And again, there were some regional and state differences. And so boxed over here on the side are data regarding stimulants. And shifts from blue to other colors indicate that higher percentages were occurring with each percentage range at the top of the figure here. So in 2021, methamphetamine co-involvement was highest in the Pacific, as well as in West Virginia and Kentucky. But as you can see, it was still in that 30 to 40% range for most of the Midwestern and Southern states. And then for cocaine, it was the highest other drug class found in overdose deaths, particularly highest in the Northeast, as well as some Great Lakes areas, and then some of the southeastern states, including Virginia, North Carolina, and Florida. This figure depicts the percent of fentanyl overdose deaths that also included stimulants. And so this is broken down by state and by year, starting with 2015 in the dark blue, and then ending in 2021 with the red data points. And I do apologize that this is a little hard to see, but I just wanted to capture all of the states and make sure people could find theirs, or just to see these general trends. The major takeaway from these data is that you can see the shift from left to right of the data points over time, highlighting that essentially all states experienced an increase in the proportion of deaths involving stimulants and fentanyl between 2015 and 2021, with a substantial increase in most states, ranging from 30 to 40% all the way up into the 60%. And so the states with the highest proportional increase included Alaska, Hawaii, West Virginia, Rhode Island, and California. And just for our reference, our state here in Vermont was number 9 on this list. More specifically, here in Vermont, cocaine was involved in more opioid-related fatal overdoses than any other drug besides fentanyl in 2022. And so this number was at 49%. And this figure depicts the steady rise in the number of cocaine-involved overdose deaths that has been happening since 2015. As you can see, the percentage of deaths involving cocaine did remain relatively stable from 2010 through about 2015. And then along with the emergence of fentanyl in the drug supply, we have seen this number increase steadily year by year. And preliminary data for 2023 through November of 2023 also indicate that cocaine was involved in approximately 58% of fatal overdoses. So again, just in this last year, we've seen another 9% increase and up from 49% just a year ago. Now, all the data thus far that I've been presenting have focused on fatal overdoses, but the patterns do appear to be similar for non-fatal overdoses as well. In a recent study by Corthius and colleagues, they examined the associations between methamphetamine and opioid use on non-fatal overdoses in rural communities. What they found was that non-fatal overdoses were highest among people using both methamphetamine and opioids at 22%, versus opioids alone, which was at 14%, and then methamphetamine alone, which was 6%. Additionally, individuals using both methamphetamine and opioids also reported the least access to treatment. Across all 3 groups, past 30-day cocaine use was also something that was commonly reported. And of the individuals who reported using methamphetamine alone, only 17% reported having access to naloxone. And that final data point on access to naloxone is an important one, especially considering the current drug supply, in that drugs may be adulterated with other substances, such as fentanyl and xylazine. For example, a recent study was looking at drug checking surveillance was conducted by Wagner and colleagues, and they found that about 12 to 15% of powder methamphetamine and powder cocaine samples sent into this drug checking service also contained fentanyl, and that this presence varied somewhat geographically. However, fentanyl prevalence in other forms, so in crystallized forms of stimulants, so crystallized meth and crack cocaine, it was not as common. Additionally, they also found that other adulterants like xylazine were occurring in the samples that were being provided. And this is important when thinking about individuals whose primary drug is a stimulant. They do not report opioid use. So like those in the methamphetamine alone group with the Corthius et al. Study. Thinking about that group, those individuals may be at an even higher risk for fatal overdose if they used knowingly or unknowingly products that contain fentanyl, yet did not have access to things like naloxone. So taken together, these results suggest that overdose deaths involving both stimulants and fentanyl grew a staggering 60-fold between 2010 and 2021. Second, the most widely used stimulant does continue to vary by geographic location. And so cocaine is the most common in the Northeast, and methamphetamine has been the most common pretty much in most of the rest of the United States. And then finally, the current situation does highlight the importance of and a pressing need for effective treatments for stimulant use disorders and for those treatments to really become readily available. With an adulterated drug supply, individuals with stimulant use disorders are at an elevated risk for overdose, especially if their primary drug is a stimulant, and that individual does not have, say, an opioid tolerance, MOUD, or has limited or less access to overdose reversal education. Unlike opioid use disorder, at present, there are no FDA-approved medications for stimulant use disorder. Recent research has identified several classes of some pharmacotherapies with potential efficacy. However, as it stands to date, the most reliably efficacious intervention for treating stimulant use disorder is contingency management. Contingency management, or we might also describe it as CM for short, this can be defined as a behavioral technique that is employing the systematic delivery of positive reinforcement for desired behaviors that are incompatible with, in this case, stimulant use. And so CM is really a protocol-driven intervention that includes a preset schedule of incentives. So for example, something like gift cards, that increase in value as participants demonstrate extended periods of stimulant abstinence, which would be evidenced through something like stimulant negative urine samples, or for the completion of other target behaviors. In a meta-analytic review of treatments for cocaine use disorder, Bensley and colleagues looked at 157 studies comprising 402 treatment groups and about 16,000 participants. In their results, only contingency management was significantly associated with an increased likelihood of having a cocaine negative test result. Thus, in their conclusions, they note that contingency management was associated with the highest reductions in cocaine use among adults out of any treatment that was assessed. In another systematic review, Brown and DeFulio examined the results of studies on contingency management for methamphetamine use. And so the outcomes they were assessing were drug abstinence, treatment retention, treatment attendance, sexual risk behavior, mood, and then they were also looking at some other treatment response predictors. What they found was that contingency management resulted in reduced methamphetamine use in 26 of those 27 studies. In addition, it was associated with longer retention in treatment, higher attendance in therapy sessions, higher use of medical and other support services, less risky sexual behavior, and then was also associated with increases in positive affect and decreases in negative affect. The authors noted in their conclusion that the evidence suggests strongly that outpatient programs that offer treatment for methamphetamine use disorder should prioritize adoption and implementation of contingency management. So the positive outcomes of contingency management for treating stimulant use have also been observed for patients that are receiving medication for opioid use disorder. So for example, in a systematic review and meta-analysis conducted by researchers here at the Vermont Center on Behavior and Health, Bolivar and colleagues found a medium to large effect size on abstinence at the end of the treatment assessment, so an effect size of 0.7. In doing so, they note that these results provide evidence supporting the use of contingency management in addressing key clinical problems among patients receiving MOUD, including the ongoing epidemic of comorbid psychomotor stimulant use. Taken together, the evidence for contingency management for treating stimulant use at this point is now well supported by numerous meta-analyses like those just described, and at this point, over 3 decades of randomized clinical trials. However, it's only been implemented in real-world settings minimally outside of the U.S. Department of Veterans Affairs, although in the last few years that does appear to be changing, and the zeitgeist for trying to disseminate CM does seem to be growing. In a recent commentary, I really like the way that Proctor and Reiser captured this paradox by referring to CM as the most effective evidence-based treatment you've never used. It sums it up in one sentence very nicely. And this is due in part to numerous challenges that really have historically impeded its widespread adoption and dissemination. One major challenge is that currently there is a limit on the amount of federal funds that can be used per person for CM. Also, there are some other issues, including some confusion around the use of CM and how it relates to anti-kickback and inducement regulations. Another issue includes resistance to the idea of using incentives to promote positive change. So for example, the stigma associated with paying individuals to not use drugs. Another challenge relates to the absence of evidence-based training and implementation strategies. And this is due in part to these other barriers and the fact that most studies have been conducted in university settings with trained staff and not in community settings, at least to date. And finally, another challenge is related to creating evidence-based CM protocols, which do involve deciding on numerous parameters that go into designing using an evidence-based CM protocol. And to date, there's at least no well-established guidelines to do so. One looming question that often is asked about for expanding the use of CM is, this all sounds great, but where does the money come from? And so at present, there is a cap of $75 on the use of incentives per person for a year, which is way below the empirically supported incentive amounts. In fact, a study conducted by Nancy Petrie and colleagues back in 2004, they found that a CM intervention of $80 had virtually no effect on stimulant abstinence or treatment engagement. And consequently, with this max currently in place, a $75 CM intervention will be ineffective and could have other potential negative implications, such as things like CM being viewed as ineffective, which could potentially disrupt or discourage future use. In fact, many of the published protocols and studies have had max possible earnings of over $1,000, which is often provided across a 12 to 16-week treatment period. Then there's also this separate but related issue of incentives as a form of taxable income. So currently, $599 is the maximum incentive amount before the IRS would consider the incentives as taxable income, therefore requiring a $599 or a 1099 miscellaneous form to be provided to someone. And it's also currently not clear how reporting this income to the IRS, if it were to go over $599, how that would impact federal confidentiality regulations for individuals that are in substance use treatment. So for example, in California's currently ongoing statewide implementation of CM, which is the first and seminal statewide implementation, $599 is the maximum incentive amount across the 6-month treatment protocol. There's also this other related risk that if incentives are considered by the IRS to, in fact, be a form of taxable income, then this could potentially impact that benefits cliff where an individual's earned income gets bumped up, exceeds a specific amount, which could then potentially put that household as ineligible for different types of benefits. Now, while there is an ongoing push for HHS to lift the $75 limit, there are also various other strategies to finance contingency management now before that cap is officially lifted. And one opportunity to do so is to submit an 1115 waiver to CMS to allow for Medicaid funds to be used. And I'll talk about this in a little more detail in just a second. Another option is to use state funds, which is currently being done in projects that were occurring in Washington State and Montana. There's also the option to advocate for using opioid response settlement funds for contingency management. And this is something that's been done in Vermont, where the state's allocated over $800,000 for CM. And finally, another option is to seek additional funding through various types of foundational grants. Listed here are some states with strategies for funding CM that are either currently underway or in development. And I did want to note that this list is by no means exhaustive of all the states' efforts currently ongoing, and I apologize if those are out there on the call that may have been missed. California was the first state to use the Medicaid 1115 waivers, and since then, the list now includes efforts in Washington State and Montana, and applications in Delaware, West Virginia, and Hawaii. And several states are also using those opioid response settlement funds, including Rhode Island, Michigan, and like I mentioned, Vermont. Another somewhat recent update on the policy front is that the OIG has proposed a safe harbor for CM. So a link here on the page is to that page for those who may be interested. With an expected date of August 2024, the CM Safe Harbor, as is listed, would provide various provider settings with protection when implementing evidence-based CM protocols for substance use. Relatedly, concerns have been noted that to implement CM effectively in community settings, there are systems that have to be set up to prevent potential issues with waste, fraud, and abuse. So an important aspect in designing guardrails to effectively implement protocol-driven CM is going to be an important aspect and something that really needs to be thought about in a lot of detail. In 2021, the Motivational Incentives Policy Group, which is an independent advocacy group that's been working to promote the adoption of CM nationwide, created a document outlining potential guardrails. And I'm happy to share this document and other related materials with anyone who may be interested. In general, what is permissible are incentives that have a direct connection to the coordination and management of care of the target population, and CM incentives that are provided for objective, validated measures consistent with positive outcomes, so something like a negative drug test or other confirmed behavioral measures. What would not be permissible are incentives that result in medically unnecessary or inappropriate services, something to do with the kickbacks or advertising, so advertising patient incentives as a way to recruit or steer patients away from other providers. What would also not be permissible is using incentives for the purpose of increasing fees and having inadequate protections against fraud. More specifically, this document goes into describing fraud prevention guardrails that should include making sure we're using research-validated, evidence-based practices, formal implementation that's occurring using a well-organized written protocol, ensuring that rewards of an appropriate magnitude are being used, that each patient has a documented clinical diagnosis, and that the rationale for providing CM for their stimulant use disorder is there. And then other important aspects are things like ongoing attention to the processes that have been set up to ensure that waste, fraud, and abuse are not occurring. So making sure that electronic health records, attendance records are all well kept, establishing accounting procedures for the dissemination of or for the provision of incentives, making sure that there are clear protections to avoid using incentives for recruitment. So this would kind of a general blanket statement of saying no advertisements or suggestions of rebates, refunds, or kickbacks. Making sure that individualized care plans would all document specific behavioral targets of the CM protocol. So listing out things like the duration, amounts, schedules, all those procedures. And then for each patient, making sure we have a complete written accounting of the auditing, if it were ever to occur, of payments, their purpose, what's the expectation, the effort associated with providing that reward, and making sure that gift or monetary incentives and their distribution is accurately inventoried. So essentially just having, a takeaway from this is making sure that not only is the CM protocol well developed, but there are also these other policies and procedures that are set up a priori to ensure that all the accounting and auditing would be smooth and the money can be traced back to each treatment outcome being assessed. In addition to setting up appropriate guardrails for organizational systems, there's also not a one-size-fits-all when it comes to creating a CM protocol. So for example, decision makers and partners will have to decide on numerous other protocol parameters. And so a first question might be, what type of CM protocol are we going to use? And the two most common types are what are referred to as a voucher-based and prize-based, which you may have also heard the term fishbowl method used for. Both of these CM models are evidence-based with strong empirical support, and the main difference being between the two is that prize-based introduces probabilities, whereas in the voucher-based model, incentives are typically earned on a predetermined schedule of escalating values. For duration, many of the research studies establishing the efficacy of CM have used 12 weeks as the length of randomized trials. However, there is a body of research that does indicate that longer intervention durations do lead to more robust outcomes. Another key parameter is deciding on what's going to be the observable and measurable target behavior. And so examples of some common behavioral targets include stimulant negative urine samples, and those results would be immediately available. Attendance is another outcome, or some combination of those two. Relatedly, a decision must also be made on what the target behavior is. So will it be for stimulants only? Would we be using this to assess polysubstance use? Then for visits, in order to promote substantial behavior change, reinforcers do need to be delivered frequently. And so in many of the early CM studies for cocaine use, 3 visits per week were required. However, a twice-weekly schedule can be used and provide a good assessment of stimulant use if those testing opportunities are equally spaced throughout the week, which we'll talk about in just a couple minutes. And then for magnitude, or the size of the incentives that's being used, research on that optimal amount for effective treatment has not been conducted to best determine what that number would be in today's dollar amounts. However, in our reviews of the research for voucher-based CM protocols, many of the published studies have used a potential earnings of somewhere around $200 to $300 per every 4-week period. There's also the decision to use or not use what's referred to as the escalation and reset components, which have been shown to promote extended abstinence. And this is where if someone provides a urine sample that's positive for stimulants, or there's an unexcused session absence, the incentive would be reset back to the base amount. And then after a set number of negative urine samples, that would go back up to the next escalating amount. And last, it may come up whether CM should be used as a standalone treatment or in combination with other treatments. And, in describing these various different parameters, I do just want to be explicit and note that this list is by no means exhaustive. There'd be other parameters and decisions that would go into it. So using the science and evidence to design a protocol that fits is going to be really important. With respect to the characteristics of effective contingency management, there are some key considerations. First, the behavior needs to be clearly defined, observable, measurable, and something that is achievable. The incentive also needs to be one that's desirable and tangible. So for example, something like maybe a gas card or a Walmart gift card or reloadable debit card. The incentive is only going to be delivered when the target behavior occurs. So for example, if someone attends a treatment session or provides a stimulant negative urine sample and it's withheld if not. And then finally, the behavior is regularly observed. So for example, 3 times a week or 2 times per week. In working to hone in and define what a clearly defined target behavior is going to be, something that's focused, so say abstinence from only stimulants, it's on one particular substance. We've identified what our target goal is. It's objective in the sense that we were going to be relying on urinalysis, not on self-report. Those results are going to be immediately available, which is nice because it promotes the ability to provide positive reinforcement very quickly with point-of-care test results that are available almost immediately or in just a couple of minutes. Something that's going to be feasible, so cost-effective for frequent use. Can we measure this often? And something that with point-of-care cups does not take specialized training. And then that target behavior really does need to be achievable. And so with a 2 to 4 day stimulant detection, metabolite detection period, this means that someone can be earning rewards within just the first few days of stopping their stimulant use. And so the current recommendation is to have a target behavior of stimulant abstinence measured by point of care urinalysis. Then with respect to frequency, so again, measuring at a minimum of 2 times per week at least is recommended. And then making sure to clearly delineate what those attendance requirements are going to be. So if someone misses a visit, that's a missed opportunity for a reward. And then also clearly describing to individuals that that would be resetting the incentive amount back to the base and what's the process for going back up in escalation. And then a key piece is going to be scheduling equally throughout the week. So if it's Monday, Wednesday, Friday, that's easy enough if it's 3 times a week. Or if using 2 times a week, say on a Monday, Thursday, or Tuesday, Friday schedule. So spread out by 72 hours is not only capturing most of the days throughout the week, but it's also time in between to where if something were to be, or if a substance were detected on a previous test, the likelihood of that showing up on the subsequent test is going to be low. And then making sure we're providing desirable and immediate rewards. For it to be a reinforcer, it needs to be increasing the likelihood of the behavior. So making sure it's desirable. And one way to do so is providing a wide array of different types of options for individuals, starting with an appropriate magnitude for the first stimulant negative UA. And that's going to be increasing with the continued non-use of stimulants and the voucher-based model. Making sure it's immediate. So what's nice is today, we can use incentives that are electronically delivered, either through things like a gift card or a loadable debit card. Those can be provided within minutes after someone provides a negative UA. And then there's also the option to print off gift cards if someone has unreliable access to technology or if that's preferred. In describing what CM is, I think it's also important just to note what incentive programs are not contingency management. So something like having coffee or donuts provided at meetings, using small, low-cost incentives, or non-systematically providing incentives. Something like random drawings for prizes for attending meetings, that would not be CM, and certificates, parties for meeting different goals, also not CM. In the first statewide implementation of CM for stimulant use that's currently ongoing in California, one key aspect that was said about that's really helping with the success of the protocol has been the inclusion of a specific CM coordinator. So in each site where CM is being conducted, someone has that primary responsibility to ensure all the aspects of CM are implemented correctly. This individual has detailed understanding of all the details of the CM protocol. This person's the one who would be interacting with service recipients in a positive and respectful manner, and is responsible for performing all CM-related tasks that can include collecting urine samples, recording results, entering those results, following all the aspects set up for fraud prevention in the protocol, and connecting patients with clinical issues to appropriate staff. With respect to currently what's being done and what's working well, depicted here is the training and implementation process that's currently being used in California. And so this includes an initial 2-hour self-paced online training, followed by 6 hours of live virtual implementation training, readiness reviews, and then after the fact, once things get started, ongoing monthly coaching sessions and ongoing fidelity monitoring. In preparing for this talk, something that was really striking to me was that although there are now over 3 decades of research demonstrating CM's efficacy, when you go into the literature, there's not much empirically on CM in rural settings or how it might be adapted to be implemented in rural settings. And as someone who is far from an expert in this area, I was hoping to pose this question to the group of how do these considerations relate to or potentially impact implementation in rural settings? And I've tried to compile a few thoughts, but really I'd love to hear from others about this. And maybe we'll have a few minutes in the Q&A to chat about this question. Initially, my hope was that we'd be able to tie these considerations in with the published literature, but that was not the case, and I ended up with some questions and thoughts for consideration. And one consideration is access to providers, or said another way, who's going to be the person or the treatment providers in a rural setting? Then there are also issues regarding transportation and driving distance. So, for example, how far will someone have to travel to participate in a CM program? And again, thinking about the fact that this could mean coming in 2 to 3 times per week. How would we go about promoting attendance or making sure that individuals come in for visits? Would there need to be offering of driving vouchers? What are the transportation options that are available to someone? Then from the organization or staff side, there's also education and training. As a protocol-driven intervention, staff need to be trained to fidelity. So who's going to be responsible for doing so? How will competency and skill mastery be assessed? What's the plan? Is there going to be ongoing coaching and support? Another consideration is who's going to be comprising the workforce. So who's responsible for doing so? Is someone going to have competing responsibilities? Is this going to be added to someone's current role? Or will there be a specific CM coordinator? Who's going to be the person for the backup? Another consideration is what types of rewards or reinforcers are we going to be able to offer? And how do those need to be adapted? So for example, something like maybe a Target gift card is not going to be preferred if the closest one is 2 hours away. And an important aspect of CM is delivering an effective incentive. So that needs to be thought about. Then there's also the goal of expanding access to treatment. How's this going to be done? For example, something that I think would be really cool is to, if something like mobile methadone van delivery is a service that's available, could this potentially be adapted to be provided alongside so? And last but not least, with the role of technology, how might we use this approach to adapt it to create an effective CM protocol? And specific to this last point, there are some apps that are out there. This list isn't exhaustive, and there's some hyperlinks here to a few studies for a few of those companies, for those who may be interested in reading more about that. With Apps and really technology-based treatment as a rapidly emerging area. Most are still in the feasibility stage, and there are some considerations specific to their use and implementation in rural settings. So without a doubt, technology-based CM really is an emerging technology with a high upside of benefit and potential to expand reach. However, will doing so require things like a smartphone and high-speed internet or high-speed cell service? What's going to be the process for collecting test samples? Historically, CM has used urine samples and most often now with point-of-care test. If it's remote, though, how would this be done? One potential avenue, for example, is with saliva tests. However, in the California implementation, they had toxicology expert Dr. Marilyn Eustace review lots of different products. And unfortunately, none of the saliva tests were CLIA waived. And there was also some potential issues with false negatives and cross-reactivity. So the recommendation was against the current use of saliva tests in their current iteration. Then there are also other organizational and systems level aspects. So things like what's the referral process going to be? Who's going to actually be overseeing treatment? Is it the app or is it the service provider? Coordination of services, things like billing, funding, and then all of those issues as well. With the emerging interest in implementing CM for stimulant use in community settings, something that is going to be helpful is having more general materials and resources on this topic. And so as a start, in their initial funding period, CORA actually developed a provider training video on this very topic. So there are two versions of the video, one that has quiz questions and one that can be watched on YouTube. And so the course is going to be the one that will have continuing of credits available soon. And so this video highlights the basic components of CM, evidence of its efficacy, and then some other important areas and considerations. Now, in the new funding period, we're working on with the UVM Professional and Continuing Education Group on the next step, which is developing a CM certificate program. And so this course is currently planned to be self-paced online course that's completed over 4 modules that are listed here. So reviewing things like the overview of CM, core elements, implementing evidence-based CM, and also getting into important things like important barriers and for implementation, some solutions, including for how this can be done in rural settings and with rural providers. And so our tentative goal is to have that potentially rolling out later this year, so stay tuned for that. Additionally, there are also some other great resources on the CORA website on this topic and NCM in general, so just wanted to make a note of those and to definitely check those out. And that is all I have for you today. Thank you very much for your time. I really appreciate it.
Thank you, Dr. Erath, so much. If you wanted to stop sharing, I'll share mine again. Thanks so much. And we will move into questions in just a moment. And as I mentioned very quickly, we will launch this poll. I'm going to launch it now. So I know that people are still kind of digesting everything they heard, but if you could just take a minute to finish this up, we will move quickly into a few questions. We had a lot of interest, a lot of people asking questions, people chatting, people very engaged. So we want to be able to acknowledge that. I'll just give you a few more seconds here. So if for any reason you don't have a chance to finish the poll, don't worry about your continuing ed credits. You can still get them. And we're going to go ahead and close the poll up. Thanks again so much. See if I can move this out of the way. Okay. And as I mentioned, you will receive an email next week with the recording and the slides for the webinar, as well as instructions on claiming continuing ed credits. And those instructions are also in the chat. Our next community round session will take place on Wednesday, June 19th, and we're going to be happy to welcome Dr. Michael Chappell, who will present xylazine trends and public health implications for rural communities. And then finally, as you may know, UVM CORA is one of 3 rural centers of excellence. The other 2 centers are the UR Medicine Recovery Center of Excellence in Rochester, New York, and the Fletcher Group, which is located in Kentucky. And we've included their website addresses on this slide so that you can go and check out the work that they are doing. And now I will hand it over to Eleanor Broy to facilitate questions.
Thank you. I'll now read off some of the questions we've received during the session. First question, we're seeing a clear shift to stimulant-involved overdose. Is this because stimulants are becoming stronger / more dangerous? Or is it that their use is increasingly co-occurring with fentanyl, causing adverse reactions?
That's a really great question. That's the question I have as well. I think, you know, part of the situation depends on for whom and how we're discussing it. So it might be the case that it's both. Potency, at least with methamphetamine, rose a little while back, but here again, we're seeing, as like with the data presented, high rates of stimulants involved in overdose deaths in the Northeast, where methamphetamine is less common. So it's not based on just one particular type of stimulant. Part of it gets into that issue of, is someone using a stimulant that's been adulterated with fentanyl? But then there's also the risk of co-occurring use of both stimulants and opioids, putting someone at an increased risk for overdose for different reasons. So I think it's a nuanced and multifaceted sort of issue that doesn't have just like one single sort of component to the answer, which is also why it can be hard to discuss.
Thank you. Next question, can providers circumvent these money dollar limits by giving gift certificates, or does this include the gift certificates?
If there are funds available, like this is where we were talking about being creative with the use of funds. If there are funds that someone has that are available to be able to set up a protocol, it's the big barrier has been getting, public funds available to set up a CM treatment for patients. So if there is something where funds are available, like a foundation or other use of funds, it would be possible. Yeah. Just making sure it's evidence-based.
Are one-size-fits-all financial incentives actually effective across varying class backgrounds and financial backgrounds?
That's a good question. To my knowledge, the answer is yes, in that CM, the effects are ubiquitous across various different sorts of demographics, groups, in all of those sorts of ways. And a key piece there just being that the reinforcers need to be decided on and effective for those individuals. So making sure that you're aligning what those rewards are going to be with rewards that are meaningful to someone. But the short answer is yes.
This is probably the last question we'll have time for. Somebody said they're doing random screens weekly for their program. Do you have any thoughts about this?
As a CM program that they're already implementing?
I think so.
Yeah. If you're capturing behavior, just knowing like the sort of variables that go into that, by capturing behavior at one point in time over a week, it's not necessarily potentially representative of all the behavior that's occurring across that week. But it's been used in studies. Some studies that you would be increasing, say, like the incentive amount if you're going down to lower uses or lower sessions where you're collecting a UA. But it's something definitely to discuss and something that you want to kind of talk through. But yeah, I'd be happy to chat with whoever about that, those things as well. So, and generally, if anyone has any questions that we weren't able to get to, I'm happy to answer questions or meet or chat with anyone. So if you want to send my email out with that, feel free to do so.
Thank you. Thank you, Dr. Erath. And thank you, everyone. We know there were some questions we didn't get a chance to answer, but if you would like to contact us with your questions, we can forward them along to Dr. Erath and we can get your questions answered. So feel free to contact us at cora@uvm.edu. And thanks again for the wonderful presentation. And we hope you have a great afternoon.